Good morning, everyone. My name is Stephen Hernandez, and I am the Executive Director of the Connecticut State Legislature's Nonpartisan Commission on Women, Children, Seniors, Equity, and Opportunity. We are coming to you live from CTN and through Facebook Live. We appreciate their coverage. The Commission is proud to join the Office of the Child Advocate today in hosting the first of a multi-part discussion addressing despair, a children's mental health strategic webinar series. To quote a recent Boston Globe article from earlier this year on the subject, the kids are not okay. And it's clear that neither they or their parents are doing well, pre-pandemic or post-pandemic. As the article noted, even before pandemic, depression and anxiety were on the rise for children under the ages of 17. Pandemic only exacerbated that reality. The bottom line of the analysis rings true to what we have seen as part of the ongoing provider crisis, and that is that resiliency is important, but it is not enough. Children and their families are experiencing despair, and we must align and resource our mental health systems and the public and private agencies that steward them in a way that responds most efficiently to that despair. Today, we will hear firsthand accounts and lived experiences of children and their families experiencing situational and long-term needs for mental health treatment and supports. Additionally, we will hear from community providers who will describe many of the difficult situations they encounter in the field and in their perspective of what is needed to improve the situation affecting so many of our children and their families. Today, we are joined by several of our state leaders, providers, and family members. We encourage questions through the chat in this webinar and from our Facebook Live viewers. In terms of the leaders who have joined us today, I want to welcome Representative Kathleen McCarthy. I want to Representative Mary Wielander, Representative Tammy Exum, Representative Tony Walker, and Senator Kathy Austin. But first and foremost, I'd love to introduce my co-host for the day, and that is the Chief Child Advocate, Sarah Egan. Welcome, Sarah.
Hello, Stephen, and good morning to everyone. I'm so glad to be with all of you today, talking about something that so many of us are talking about all the time. And as Stephen said, this is the beginning of or part of, I should say, an ongoing public conversation. And we really wanted to have today's conversation be voices from the community. You know, the Office of the Child Advocate, for those that don't know, is an independent state agency charged with helping families and children who call our office for help and investigating publicly funded systems that serve vulnerable children. Today, we will hear, as Stephen said, from families, from a young person, and from providers about what their experiences have been over the last couple of years and what they see as the most important things to do going forward. I did want to share on a personal note, and I had been deciding whether to say this morning or not, but I decided I was going to. That, you know, I think like many others on the call and like folks listening and like folks sharing their story today, I too have loved ones in my family, including a child with significant treatment and support needs. And I know firsthand, although my story is unique to me and other folks' stories are unique to them, I know firsthand what it's like to feel my insides clench with fear and grief, panic and love, and the fear that I won't be able to meet my children's needs all by myself. And I sometimes wonder whether I should tell that story or when I should tell it. I think we all have stories to tell. And I think our stories make us better advocates, better partners, better friends, better colleagues. I hope that my experience as a mother of a child with significant disabilities, I hope it makes me a better listener, and I hope it makes me a better advocate for children. I'm humbled to do the work that I do, to be in a position to listen and work with all of you, and to help find the solutions and the changes that we all need to make sure that any child, any young person, any parent can find the information, the help, and the hope that they need when they need it. And so with that, I'm going to remember my segue, and I'm going to play a video. We did invite parents and other folks to participate, or if they felt most comfortable, to share a video of a recording of themselves telling a bit of their story. And I'd like to start us off by playing a video from a mom in Connecticut who is receiving services from the Village for Children and Families. Stephen, can you all get set to play that video?
Hi, my name is Julie, and my daughter Zoe has been receiving services at the Village since the beginning of this year. Zoe has been diagnosed with autism, ADHD, avoidant restrictive food intake disorder, as well as disruptive mood dysregulation disorder. Any one of these on its own is challenging, but the complexity that comes with the combination of all these together, as well as the cost of private insurance and the high deductible, has resulted in significant out-of-pocket expense for our family. Due to the autism and food intake disorder, Zoe has taste and swallowing issues. As a result, we have had to and continue to trial various medications in order to find one that Zoe is able to take that does not cause her negative side effects. Zoe was taking one medication that costs us $180 for a month's supply, and that was after the manufacturer coupon was applied. Unfortunately, due to the food intake disorder, Zoe suddenly stopped taking the medication after it had just been refilled. As a result, we have that medication just sitting on a shelf in our cabinet. The high deductible definitely poses a financial burden for our family, given the fact that Zoe's receiving individual therapy, we're receiving family therapy, psychiatric services, occupational therapy, as well as ABA therapy. Zoe may finally reach her deductible at the end of the year, but it will be just in time for the policy to renew, and then we're going to have to start all over with the deductible come the first of the year. Thank you.
Thank you so much. And thank you for outlining the complexity from the perspective of a family member. The fact is that so many of these individual stories really do add up to tell the true story of the crisis as we see it here in Connecticut. Next, we're going to go to our providers, some of our providers in the state, who will give us a little bit more of the rich depth of, from their perspective, of what the data is telling us. We're joined by Howard Zabronsky from Connecticut Children's Medical Center, Frank Fortunati from Yale New Haven Children's Hospital, and Linda Mays from Yale New Haven Children's Hospital. Welcome.
Thank you, Stephen. Good morning, everybody. I'm here with Dr. Mays from Yale. I'm the Chief Behavioral Health Officer at Connecticut Children's. I believe Dr. Fortunati might be delayed, so we're going to start with the two of us. And thank you for this opportunity to speak and share with you some of our thoughts and observations. Connecticut Children's and Yale New Haven Children's Hospital are the two children's hospitals in Connecticut that are acutely aware of the mental health crisis facing children and families. And because of our unique perspective, we wanted to share with you some of our observations and thoughts and recommendations. The COVID-19 pandemic has highlighted the inadequacy of Connecticut children's behavioral health care system. This system was already stretched and under-resourced prior to the pandemic. This system is clogged, and it's clear that available resources do not match the severity of need the children and families who present to medical emergency departments for behavioral health. This year, nearly 1,700 children under 18 years have spent more than 24 hours in Connecticut Children or Yale New Haven's children's emergency departments, totaling 6,770 days while waiting to be connected to behavioral health care. Discharges for children in inpatient and emergency care settings are delayed, for some by weeks, some by months, because the next level of needed care is not available, whether community-based, such as intensive outpatient or partial hospitalization, or residential care such as inpatient admissions or PRTF, psychiatric rehabilitation treatment facilities. We have together a unique opportunity to begin this important work through the American Rescue Plan, the ARPA. This funding, and we hope that we've identified priorities that you should be considering as outlined below. Our first recommendation refers to primary care. The governor's ARPA recommendations seek to create additional mental health consultative capacity for primary care physicians. Implementation of this recommendation should be an immediate investment in a program that we are all familiar with called Access Mental Health. Supporting our primary care providers is critical in supporting children and families struggling with mental health problems. Our second recommendation refers to intensive outpatient and partial hospitalization programs. These are critical community-based programs that will address directly the higher acuity of needs of kids that we're seeing now in our emergency rooms. Current wait times average 3 to 8 weeks, creating significant discharge delays for children in our emergency departments and acute inpatient psychiatric settings. And I would add, especially at Connecticut Children's, also on our medical units of children who have been medically cleared, but now are awaiting for a mental health resource. Existing intensive outpatient programs or partial hospital program providers should be asked immediately, what would it take for them to expand services if financial resources were made available? And this information should inform an immediate plan for program expansion. Our third recommendation refers to inpatient care. While we applaud the state's efforts to provide incentives to expand inpatient capacity, we would also like to recommend that our state-operated psychiatric inpatient facilities at SOLNIT and our psychiatric rehabilitation treatment facilities, those beds operated by the state, must be expanded with an ability to flex to meet the needs of children who reside in our emergency departments and our inpatient psychiatric units that are awaiting beds after being approved for this level of care. Sometimes these children are waiting weeks, sometimes months, to access this level of care. This need for a wider range of options, particularly for children in need of higher levels of care, is something that is immediately required in order for us to address the acute needs of children who are coming to our emergency departments and in our acute inpatient settings. Expansion will positively impact our ability to more rapidly discharge children and get them into the appropriate levels of care. Our fourth recommendation refers to urgent care. We again applaud the state for convening a work group that is now looking at how to develop and implement a model for urgent care. We are still unclear what these urgent care centers will look like, but we must ensure that the model provides children and families an immediate access to integrated behavioral health care and not serve as a simple stopover on the way to medical emergency departments. At this point, I'd like to invite Dr. Mays to offer some thoughts about workforce.
Thank you, Howard. So our fifth recommendation focuses on workforce retention and development. Even as we think about what children need, we actually need to also think about the workforce that's delivering those services. To date, this is a very stressed workforce, and we have recommendations to begin to address acutely and for the future. We recommend first that the state invest in workforce development and mental health disciplines, and those include social work, APRNs, psychology, and mental health disciplines through loan forgiveness and scholarship programs to encourage more people to come into the field and feel as if it is a sustainable professional development. We also recommend that we provide support for continuing education of child-facing professionals in the community, including pediatricians and teachers in behavioral health, so that they feel better equipped to meet this surge in need and feel better equipped to work with families in continuity of care. And finally, and most importantly perhaps, is to acknowledge the link between the inadequate reimbursement for behavioral health care and workforce capacity. Because of lower reimbursement, the more struggle it is to sustain these services, the less attractive these fields are, especially for outpatient services. And expanding access will necessitate changing the payment model so that we can increase the number of different providers who are willing to be in this field, willing to stay in this field to meet the behavioral health needs of children. Thank you for your time, and we very much appreciate the opportunity to speak with you.
Thank you so much, and thank you both, doctors. If that is the bulk of your presentation, I'm wondering if perhaps you feel comfortable sharing those recommendations, very thoughtful recommendations, and also recommendations that span the need with our legislative leaders after this production, so that we can have them in front of us as we move forward in the next few months, as we talk about how to resource and how to integrate our system. So we appreciate that.
We'd be happy to do that.
Very delighted to do that.
Thank you, doctors. Next, we're going to hear directly from one of our participants with lived experience in these matters. You know, to the point of the child advocate earlier on in the broadcast, and many of you who are responding in the chat and also on Facebook Live, this really is a question of understanding individual lived experience and how those lived experience abut against a system that is there and intended to be there to address those needs. So next, we're going to hear from Ross Tyne. Ross, I'm sorry if I'm mispronouncing your last name, but Ross is a student, and we welcome you, Ross, to the presentation today.
Thank you very much. Hello, my name is Rosario Tyne Jr. I am president of the Weathersfield High School class of 2022. I'll tell you a little bit more about myself. I play baseball for Weathersfield High School at the varsity level. I play for the Connecticut Capitals organization. From what you can tell, I'm most likely a normal kid, what you can tell. I mean, I got a lot of friends. I have a girlfriend that loves me dearly. I have a family who, at our family gatherings, I'm always get called the favorite. It's great and it's funny, but I always get called the favorite. And looking from the outside, you would have no idea, none. Everybody that I have told has said, what, how? And it's truly incredible about how so many people can hide their mental illness. And here's my story. So growing up, I was most likely an anxious kid, and not to say most likely, I was an anxious kid. It was something that I didn't realize. It impacted the way I performed in the baseball field. It was a type of anxiety that I didn't know how to control. My mind would spin. And then all of a sudden in February of 2021, something snapped inside of me and depression set in and the anxiety came through the roof. Panic attacks came. You can name it. I would cry myself to sleep, and I don't know how I got through it. I remember into March, it was a reoccurring thing. I'd cry myself to sleep every night. I would be so anxious in school, baseball. I shut down for a month. I threw nothing in the spring because of my anxiety. And I was spiraling down a path that most kids, I don't think, would have came out of. And the suicidal thoughts set in. And on May 2nd, 2021, I attempted suicide. And that was the day I made the decision to go to the hospital, Connecticut Children's Medical Center in Hartford, Connecticut. And before that, I wanted help. And I don't know, it's a miracle. I believe it, how that I got through it. I reached out for help. I was at the time taking a medicine for acne, and the side effect is depression. I don't know if that was the causant of it. I mean, there was a lot of things going on in the spring for me. You know, I was planning an uncertain prom. It was my responsibility, and you know, baseball and school was my junior year. I took my SAT. It was not a good score, and I am not capable of such a low score. I'm more capable of that, but that's besides the point. And I remember I called my pediatrician's office, and I asked for help. My yearly physical, my pediatrician offered me some numbers for therapists, but unfortunately during the pandemic they were over Zoom, and I didn't particularly like that. I wanted the human to human experience, and I'll get into that a little bit more in a second. But I declined the help because I didn't like it being over Zoom or over online. I don't like that very much. And then I spiraled down. And then I remember one day I called, and my pediatrician, they gave me some numbers. And the next day I called, and I was in complete despair. And that was the day I attempted suicide. And I went to the hospital, and I was there, and it was amazing to me how so many kids struggle. It smacked me in the face. It was incredible. There were people that were there for days, and all they wanted to do was just leave, and I felt terrible. And then I met the transition clinic, and they have been, when I say, absolutely unbelievable. Absolutely unbelievable. I'm a person that gives credit when credit is due. I got prescribed medicine, and I saw a therapist through the transition clinic, and I can now say that I'm a lot better. I'm a lot better. They transitioned me to a therapist and another psychiatrist, and I'm on my medicine, and I'm a lot better, but I still struggle. I still struggle immensely. And it's still a tough job. It's something incredible, but I'm working through it, and I'm a lot better, and I'm still here, and I'm not going to go anywhere now. And one thing that really helped, and I think one thing that can help, and I hope that all of you realize, is the power of a relationship with a person. All these things, and things that we can do, and through the hospital and community service and all these things, they're great, and I am not really degrading that. I am just saying that the power of a relationship with a person is amazing. There was a best friend of mine. I will say this: he saved my life. He did it outright, come and like pull me away from trying to attempt it. No, he was there by my side every single day. And I remember there was one time I was in my kitchen counter, and I was shaking and hyperventilating, and I'm like, don't do it. Do it for him. Do it for him. Don't do it for him. And he saved my life. And that's how we need to focus, I believe. Partially, we need to focus on just the power of a relationship from person to person. You can save somebody's life by just being there, not saying obnoxious comments, because trust me, there's been comments made to me that are insensitive, and they have no idea. They have no idea that what I go through and what everybody goes through. And again, I want to thank everybody for listening. The transition clinic was great. I think that's a great thing. I think there's a lot of great things going on, and I hope that we can build on it. Thank you very much.
Ross, first of all, thank you so much. Listen, I know that for those who are watching now, whether it's adults who are watching for whom this resonates so clearly, in their experience, whether it's a young person who may be watching right now that is hearing a message not only of hope, but of support and a pathway to that support through your inspiring story. To the majority leader who's joined us as an attendee today, Jason Rojas, there are people who are listening who can actually help start stitching this work together in a way that makes sense. And it is inspirational stories like your stories of do it for them is really what's really going to resonate for us today. So thank you so much, Ross, for that story and for sharing that with us today. Thank you. Next, we're going to hear from, firstly, from our child advocate, Sarah Egan. Hi, Sarah, your reflections.
Yes, thank you. First, I want to thank Ross for telling his story. We had a lot of conversations with folks because we wanted to hear from parents and young people. And it's so hard to come in public and tell your story. It's people come from such a place of deep vulnerability, and it's hard to do that. But it makes a difference for folks when they can do that. And for Ross to come and share his story, please just know that it makes a difference, and it helps folks identify, connect, and feel less alone. Which is so important. I did want to lift up a comment from one of my colleagues, Barbara Fair, who shared a comment that I won't read it all, but about the needs of our children who are incarcerated and in the custody of the state. And we cannot forget about those children. So many boys and girls who are incarcerated in our prisons and our detention centers have a tremendous amount of unmet need and are dramatically underserved in our communities, our human service system, and our mental health system. And I really appreciate the work that Barbara does every single day, the leadership and the courage that she shows to make sure that we never, ever forget the tremendous work, civil rights work, the mental health work, human rights work on behalf of some of our most vulnerable citizens and children in the state of Connecticut. So I wanted to get that out there today. Thank you, Barbara, for that work.
Thank you, Sarah. And thank you again, Barbara. I know that there are comments that are coming through the chat. Please know that whether you're commenting live here in the webinar or you're commenting on the Facebook site, we will be saving your comments, and they are actually to be circulated among leadership. This is something that they see, so your voice is being heard. Thank you so much, Sarah, for that. Next, we're going to hear from Tisra Kemp. Tisra is Vice President of Community Support Services and Engagement at Clifford Beers, one of the premier serving organizations in the state. Welcome, Tisra.
Thank you. Thank you very much, Stephen. First, I just want to thank Ross. Tough act to follow. I have a son who's also a senior in high school, and just thank you so much for having the courage to tell your story. I want to thank the Office of Child Advocate and the Connecticut General Assembly for hosting this event today. I am Tisra Kemp, the Vice President of Community Support Services and Engagement. And Clifford Beers has been in the community for quite a long time, founded in 1913 by a New Haven resident, Clifford Whittingham Beers. We offer many programs and services to children and families who really strive to achieve mental health and wellness. We are convenient, and so we are community-based throughout Region 2, Greater New Haven, providing effective care, clinic-based, community-based, as well as home-based. I oversee all of our communication, care coordination programs, which is a community intervention that really utilizes the wraparound philosophy. And what is our philosophy? It's one family, one voice. I love that was mentioned, where we have to really look at the extreme complex needs that our families are facing. There are nearly 140,000 children in Connecticut who have complex physical, developmental, behavioral health needs that really require frequent and more intensive services. And to expect our families to continuously come to us, it's just a barrier. for families. And so we are very proud that we go into the community and meeting with families in the community and serving not just a child, but the whole family. The families find themselves working with multiple providers and often serve as the primary source of communication between all of these providers. We saw in the first story about a woman who has all of these complex needs for her child, and to have the burden fall on the family, it's just too cumbersome. And a lot of families, at least 40%, are not reporting that they need help or receiving help. And so Clifford Beers, we've served a total of almost 5,000 children last year, caregivers 700. Our screenings and our trauma trainings increased, where we served 2,600 trainings and screenings, and adults were served at 849. And so our practice of the wraparound approach to family care, although it's not clinical, it is a very therapeutic intervention for families and the communities in which we serve, while also infusing an equity lens into our work. And so those who have less, we have to be able to give them more in the way of access to care and preventative services. So we address the social determinants of health, and given that 50% of health incomes are driven by social determinants, wellness outcomes for families will be greatly impacted by the degree to which providers across sectors understand that not only families' physical and behavioral health concerns, but then the social and economic conditions that may cause these concerns or really present barriers in addressing them, like incarceration. Care coordinators are prepared to support the family and connecting the family to the various social services to address those needs, such as housing, food insecurity, employment, and other critical supports. We have worked very hard, especially over the last year, in the increase that we're experiencing in despair and crisis for families, and ensuring that we have coordinated our community collaboration and really increasing those, our collaboration, the services, how we streamline services for families, how we support families in accessing services, but then also addressing the community violence. Without being, I'm in New Haven. And so it seems as though every day the violence, the tension, the trauma is increasing in our community. We've created a community healing support team where we are now in collaboration and working with juvenile probation, police departments, community-based organizations, and those who are just natural supports in the community, and really being able to provide the aftermath of a community violence situation and the trauma that the whole community is experiencing at this time. We are attending funerals and vigils, and we're running healing circles in our community. The educational needs that have increased for children and families, in supporting our local learning hubs and ensuring that families and children have access to the supports that they need to ensure that they have an equitable education. When we think about the social determinants of health, it's the economic stability, it's the neighborhood and physical impact, it's their education, it's their food, the community and social context, and then the healthcare system. All of those are combined, and that's really the work of our care coordinators in ensuring that all of these pieces are aligned when we work with our families. Some of the recommendations that we have to begin to really address the despair on a statewide level is early identification and treatment, and to be really starting to focus on our prevention and as well as the intervention, coming from an and both approach, and addressing both the immediate needs and the long-term needs through integrated care coordination and case management for the whole family. We ask that you consider care coordination a therapeutic intervention for families and the impact care coordination is having on families. Develop a state payment model through the work of INC. And so INC really focuses, and the framework is early identification and treatment, integrated care coordination and case management for families, and then develop an actual statewide payment model. Right now, we work and our care coordinators are funded through grants and through the Department of Children and Families and other entities throughout our state to ensure that our families have access to care where they're able to go to the family. So they go to the family's home, they work with the whole family to be able to ensure that our families are better off. Timely access to an optimal mix of integrated related health services, providing care for families to the right services in a timely manner. And so again, when parents and families are so overwhelmed with all of the different pieces that they have to pull together, it's important that a care coordinator, someone comes into the home to be able to ensure that they're getting those services in a timely manner. The wait list is just not equitable in crisis. And speaking of equity, address the isolation and the distrust for mental health services in our community, utilizing an equitable lens to our work and how we serve our families. And so, yes, wait lists that's equality to have a wait list. But equitable means when we look at our families who really need those services immediately, we bump them to the top of those wait lists to get those families those supports. And so I'm happy to answer any questions as they come in. And I just thank you again for giving us the opportunity to be a part of this very important conversation.
Thank you so much for that. You know, as we think about care coordination and we think about those human and social connections that really are key, you know, what you've described really is that type of coordination at a grand scale. It's what Ross described as a need for that human interaction, but really systems working together across silo in a way that you describe, which is equitably, right? And really focusing resources where they're needed the most. And whether it's our populations that are in most need or our populations that are the most vulnerable. That's what care coordination helps us achieve, is looking at the whole system and understanding where the pressure points are. So thank you so much and for that presentation. It seems to me that the way that Clifford Beers and the recommendations that I know that you're going to share with us is really thinking about that coordination, how it all works together. It resonates with what our medical professionals are saying. Look, we can't do this alone. You can't put all of this burden on one part of the system. It has to be shared and it has to be coordinated. So thank you so much for that, for raising that up. And I know that there will be questions that will be presented later on. And thank you for all the work that you do. Next, we're gonna share a really touching video from one of our leaders in the state, Representative Tammy Exum. Representative Exum, I know you're with us in our little Brady Bunch screen here. We're going to share your video, if you will, and we really appreciate that. What you are doing is that you're bringing a face, just the way Ross did and others have done. You're bringing a face. There's no place in the state that is immune. There's no person that is immune from these issues. So thank you, Representative. We're going to play your tape now.
Good morning. I'm Tammy Exum, and I'm here today to share my story, which I think will give an informative lens into the state of the mental and behavioral health situation as it relates to children here in Connecticut. This is a difficult moment for me, and the events that I'm about to share are personal, recent, and persistent. I will also be reading my comments because it is such an emotional topic. Still, I feel called to be here at this place and time, if it will help in the quest to deliver better services and supports for the children and the families in our state. I won't state the name of the person involved, but will simply refer to that person as a loved one or as he or him. In June 2021, a loved one was taken to the emergency room at Connecticut Children's and Medical Center after attempting to hurt himself. The staff was wonderful. He was quickly admitted, assigned to a person to monitor him until discharge, and his immediate medical needs were managed. He was also provided with a book, a game, and a blanket to provide some comfort and distractions while in the ER. Later that evening, it was determined that he was medically stable and would be transferred to the behavioral health side of the ER because he would need to be evaluated before he could be discharged. When the nurse came from the behavioral health side to make the transfer, I asked if he would be given his medication, and she asked about his meds list, which had already been provided and recorded upon entrance to the ER. Then she grabbed a paper towel and jotted down the medications, and while I didn't think this was standard protocol, I assumed that she would record them once he was transferred. Next, we were told that there were no rooms available, so my loved one would be in a bed that was in the hallway, right outside of the nurse's station. It turns out that he definitely was not alone. There were several beds in the hallway, and the one closest to him was a very small child, balled up, covered by a small blanket. It gave me pause. I was told that I could stay with my loved one, but under the circumstances, all they could provide was a hard chair placed next to his bed. I understood, and I asked if they had a noise machine to help with the sounds, because he definitely needed some sleep. I also asked if he would be given his medication, as that was part of his routine, and it would make him sleepy while also alleviating some of the anxiety around having to stay in the hospital. The noise machine was provided. The medication was not. After sitting with my loved one for a while, I realized that I needed some sleep as well, and I went home as my loved one fell asleep with the promise to be back in the morning, and this was heart-wrenching for me. The next morning, I received a phone call from a social worker at CCMC. She wanted to review the events that led to the admission of my loved one. I answered her questions and asked for an update. She had little to share except that he was transferred into the overflow section. I asked if he had eaten, which is another whole testimony within itself that exceeds what I'm here to share today. And I asked if he had been administered his medication. I explained how long it took to get his medications and dosages right, and how it is extremely difficult to get his anxiety in control once it spirals out of control. I also suggested that anything sensory related could be calming under the circumstances. She asked me to provide the medications that he was taking, and I shared with her that I had given that information twice, both when he was admitted and when he was transferred. She needed them to be provided again, and that she would check into the matter. I told her that I was on my way. I arrived, and the place was quite different from the quiet that I had experienced the night before when my loved one was transferred around midnight. This time when I went in, I was asked to secure my items in a locker, and then I was escorted to the back space where my loved one had been transferred. On my way to this new space, I was led through the halls that were filled with young people in hospital gowns. They were on the floor, and some were in rooms as I walked through. There were easily 30 or more children there, children in some level of distress. I entered a room consisting of 5 beds with 5 patients, a supervisor, or you might call her a sitter, 1 adult visitor, and 1 adult that I think was from DCF. My loved one looked distressed and started to cry when I walked in, and I wanted to cry too, but I couldn't. The room was dimly lit, and there was no natural light. The social worker came in and said that a nurse would be coming by to discuss his situation and next steps. I brought my loved one some sensory items to fidget with, as I was hoping to soothe him in some small way. We started to talk a bit, and he indicated that he had eaten little, which I'd stressed was very important for the staff to tend to, given another significant situation through which my loved one had been dealing. As my loved one calmed down, we chatted, he ate his lunch, we watched TV and waited for the nurse to come by. I couldn't help but take in all that was before me. I think the little girl from the night before was in the room. She may have been 10 years old. She was working on a puzzle with 2 other girls around 15 years of age. I was struck by how little and how young she was, especially as I tuned into the conversation. The older girls were having a conversation and the word prison came up. She asked what a prison was. They couldn't believe that she didn't know, and they told her it was like a jail, but she didn't know what that was either. One of the girls then went on to tell her that it was a place where very, very, very bad people went, and that satisfied the little girl. She told the caller, oh, she then started to feed a stuffed animal until she received a phone call. She told the caller that she wasn't ready to come home yet, but also told how she had brushed her teeth 5 times and had used up all of the toilet paper in the bathroom. It wasn't even noon. Caretakers came and went. A wonderful lady asked if we needed anything to be more comfortable. The children were well monitored. Shortly afterwards, the nurse came in and asked to speak with me. I asked her what was the delay in getting the medications to my loved one. It was a matter of time before his anxiety would be out of control, and they had the tools to mitigate that. She explained that they wanted to have him seen by the psychiatrist first. I asked when that would be taking place. She said the next day. I couldn't believe it. I said, that makes no sense. He would be made to go cold turkey from medications that are rather effective in assisting with his anxiety and more, given that they were offering no other interventions other than to keep him safe, when we had some tools right before us to assist until he was evaluated. I was incredulous. We continued to talk, and once again, I was asked for his meds list for the 4th time. Again, I provided it. She ended our exchange by saying she would check into getting his medication and how she wished that every child here had an advocate like me. While I appreciated the compliment, I was so saddened by what I knew was happening all around me. Kids being in there without an advocate or a loved one, not getting what they needed because of the way the system is structured. They're caring individuals there. It's because of the way the system is structured. My loved one was eventually given his medication. So as we continued to sit, I asked the sitter, who decided when my loved one would be released and how the process worked, how was information being collected and communicated to determine whether or not he would be released that day. She told me that was a part of her job, that she monitors the kids and inputs information so that the team has information on how the child is doing. I asked who was monitoring from a clinical lens, and she said that the social workers and nurses are a part of this as well. I wasn't satisfied with this answer because I couldn't see that anything was being done to help my loved one other than to keep him safe, which I agree is important and foundational. But here he sat in bed in a dim room with strangers watching SpongeBob and wouldn't receive input from a psychiatrist until the next day. He was put into this place because of the incident one day prior, but had no real mental health intervention. Not even the lowest hanging fruit, the administration of his medication. I was perplexed. I asked if we could possibly see a psychiatrist that day because I thought the atmosphere was actually attributing to his stress instead of mitigating it, and I didn't see anything changing that day. I was told that it was unlikely. I asked when he might be discharged, and they told me it couldn't be until he saw a psychiatrist. We were trapped. A couple of hours later, a person entered the space and asked to speak with me. It turns out she was a psychiatrist. We discussed the events that brought us there, my loved one's history, and next steps. She said she would feel comfortable discharging my loved one provided the following: that we implement a safety protocol within the home setting. CCMC would then arrange to have Wheeler Clinic visit that evening. We agreed upon 7 p.m. CCMC would set up a referral for ICAPS. I agreed, and within the hour, my loved one was transferred to another space, brought his clothing, and was discharged. I was glad to be leaving CCMC, but nervous about next steps. We did the safety protocol, and then we waited for the Wheeler folks to arrive. When 7 p.m. came and went, I called Wheeler Clinic. They never received a referral. I couldn't believe it, particularly considering the reason for the referral. Fortunately, they said they could send someone over. Someone came over. We basically provided information on why the referral was to be made and started the intake process. By the time all of this took place, my loved one had fallen asleep on the couch. It was 9 p.m. and it had been a very long day. The person from Wheeler also told me that she would check into the ICAPS referral. She called me the next day to tell me that no referral had been put into place by CCMC, and then she would start this process for us. I was so incredibly shocked by this. I don't know how much more serious the situation would need to be to have supports and follow up put into place. But this simply did not take place. I decided to make a couple of phone calls back over to CCMC. I called the social worker since I still had her phone number and she did not know about the referrals that we had received. Then I found a number for care coordination and I called them, and they had not received a referral either. I decided to also call and complain to what I would call the ombudsman for CCMC and never received a return phone call. Here we were dealing with a crisis, and the ones that I thought would be there to assist simply were not. The coordination of care was not coordinated, and no one seemed to care. The person from Wheeler was supposed to come twice a week for 6 weeks, which the psychiatrist was hoping would give us enough support until ICAPS would begin. Instead, we had 2 visits from the Wheeler clinician. She made a referral to the Leo Clinic ICAPS program, and we were informed that Wheeler had at least a 3-month waiting list. But then she never followed up again. I actually called her to see if it was her intention to check back on my loved one or not, and she indicated that she had been very busy. I started to inquire about how to get the support we needed with others, anyone that I thought would be helpful. I also called the Office of the Child Advocate, Sarah Egan, to just tell her my story, because our experience, I truly believe, is a common experience. It's a sad experience. It could have been a tragic experience, and it could not go unaddressed. Shortly thereafter, I received a phone call from the care coordinator, Nancy, from the Connecticut Children's Medical Center. She was thorough, concerned, patient, and I was so grateful to her. When I explained what had taken place, she was very concerned. She listened patiently, apologized. She apologized and connected me with her supervisor. Once we connected, I was told that there was an ICAPS program available for folks with private insurance through a CCMC grant program run in collaboration with the village. My loved one would qualify, and there was an available spot. We were so grateful. But it was too messy, disjointed, and too long. We have resources. While working through this process, my loved one had a therapy team. Thankfully, to provide some support, he had a wonderful camp, the Ebony Horsewomen in Hartford, and benefited from various resources that my family could provide. I was able to speak with an array of providers, try to work through a very complicated system. It took time, it took energy that many simply don't have. Our children, their literal lives are on the line, and we can't even rely on the system that is in place to protect and support them, to do more than the basic job of holding a child in a space to keep them from harming themselves, which is important. But they and their families need and deserve more. They are vulnerable. They're vulnerable to those in the same space, to the system that takes days for a proper evaluation, to the care coordination delay of 48 hours when you don't have 48 hours, to a lack of resources, such as a bed and a room. Someone to actually read the history provided so it doesn't need repeating 4 and 5 times, and then someone to do what's right for the child. All things said, I consider my story to be a successful one. My loved one receives ICAP services and more, but this is about far more than my loved one. This is what compels me to speak out on something so personal and so painful. I am speaking out on behalf of the children and families in Connecticut who are suffering from mental health issues. When they are at the point of reaching out to the hospital for assistance, they have hit rock bottom. It's sad for them to realize that they can still actually go lower. We can and we must do better. Thank you for listening.
Thank you so much, Representative Exum. I just really want to thank you for your compelling testimonial. You know, it just really does highlight what happens when we rely and put all of the burden on only one component of our system. It's almost unfair, because what happens then is that parents like you, caregivers, loved ones, right? Loved ones, I should say, and parents out there who are dealing with this with their children and other family members, they are left alone, and they are left to have to advocate for themselves without the outside and inside coordination that is so necessary. We have to share this burden among the other parts of our system and ensure that care coordination doesn't leave any one of those components alone to do this on their own. So Representative Exum, I know you're here. I don't know if you would like to add to your presentation, but again, I just want to thank you on behalf of all who are listening, and on behalf of all of who are here to try and get as much resources into as many of this coordinated system as we can, so that none of it is left on its own to manage this crisis. Thank you, Representative. Thank you so much. Next, I'd like to welcome Ann Smith. Ann Smith is the Executive Director of the African Caribbean American Parents of Children with Disabilities organization. That's AFCAMP for those of us who work closely with Ann Smith. Welcome, Ann. We are so happy to have you here today with us. Welcome.
Thank you, Stephen. And it is indeed a privilege to be here. And at the same time, I just do want to take a moment to acknowledge the courage that we have seen from Zoe's mom when we first started out, Representative Exum, Ross, and to highlight that what we have heard from these courageous individuals who have come on and publicly shared their experience is something that we see and know is occurring with many, many families, many children throughout our state. In addition to my role as the Executive Director of AFCAMP Advocacy for Children, we have been for the past 20 years empowering parents and families, engaging systems to improve children's lives. And one of the opportunities that I've had is to serve as the tri-chair of Connecticut's Children's Behavioral Health Plan Implementation Advisory Board. As I listened this morning, I thought about my three major points that I wanted to make when I received this invitation, which I very much appreciate. And it came to me that of all of the stories that we heard, the reports that we heard, and I also do want to recognize that our child advocate also shared a very personal perspective. And then I will just say that I can certainly relate to what it is like to seek services for your loved one and have to go through the kind of experience that Representative Exum has just shared with us. I'm going to ask you to just think about this. If that was the experience of a state representative, whether they knew that or not, a well-educated, competent, caring, committed, involved parent, and that is the treatment that she had to endure and how hard she had to advocate. Think about what the experience is of our children and families who may not have that same level of opportunity and privilege, who may not have that education background, who may not have that experience to advocate. You know, it's very difficult sometimes to try to get the system to do what needs to be done. And that's one of the focus points of our Children's Behavioral Health Plan Implementation Advisory Board. And there are very many members of that advisory board who are on this call. And then our committee of cognizance is the Children's Committee, and representatives and leadership of that committee are also on this call. But I do know what it is like. You turn to the system for help, and the system fails you. So what are we here today with an opportunity to do? We have an opportunity to look through a lens that some of us may not have opportunity to see, and some of those who are on the broadcast this morning also may not really understand what it is on a personal level. So I think it's just really important that we have this opportunity. And we tie it back to some of what I've heard this morning. And as I thought about, like, if I had to make 3 key points, what would they be? I think that all of those points have been made in some way, shape, or form by those who came before me this morning and spoke. So what I would like to do with the time that's allotted to me is I just want to try to pull it all together and put it in the context of some of the work that is being done, and have people to recognize too that, you know, we in Connecticut are very blessed in that we have a system that there are other states who admire what we have. And that's great, but we can't sit on our laurels. And we've heard stories this morning that really demonstrate that we have work to do. So where are our challenges? I think we've gotten a good representation of what those are. I would like to have us focus on some of those recommendations for how can we get to that place where we have an optimal children's behavioral health system here in Connecticut. What should we identify as some of our priorities for the coming year? For this unprecedented time, a time of challenge like we've never seen, but then also a time of opportunity that I believe is a once, at least in my lifetime, a chance for us to do some things and do them a little differently. So 1, we have already heard from Dr. Savansky that we have these ARPA dollars that have come in. We have federal funds that have come into Connecticut. What are we going to do with those funds? We should be using those funds in order to implement those kinds of innovative services that will support our children and families that heretofore we've been told that we don't have the money for. So here's our opportunity to use that money to build up our family and peer support systems, to make sure that we are using individuals' expertise, those who have lived experience, to inform the system, because no one knows better than those who are experiencing the despair, what is needed in order to redress the system and to strengthen it so that it can adequately serve. What would we do with those dollars? What should we be doing with those dollars? I offer to you that, yes, it is incredibly important for us to make sure that we do address what is happening in the hospitals, what is happening with our children that are languishing because they don't have any place to be discharged to. That is incredibly important. I think also, though, we want to take a look at how can we invest in those services and supports that can keep our children from even ending up in the ER and NCC. So we are looking at an opportunity for us to invest some of those dollars in prevention and intervention services, but to not stop there, because I think one of the things that we've heard as well is sometimes you're discharged into the community and you don't have the adequate supports to make sure that you don't relapse and end up back in the hospital. We did have the representative from Clifford Beers talking about INC, an innovative project, but grant funded. It's one where care coordination looks to wrap around the child and the family, because what we know is that children don't grow up in a vacuum. So if you want to heal the child, you need to also help the family. This is where a focus on family engagement that is authentic and that is also given an opportunity to inform and support the system is really key. We've done some of that in Connecticut, but we have not done enough, and there's more that can be done. I would also suggest that we use some of those dollars to ensure that we are supporting and broadening our system of care such that it also includes those providers that are in the distressed communities, those providers that pick up the pieces when our larger organizations and those that most frequently end up with those grants are not able to meet all of the cultural, geographic, and other needs of our children and families. And so here's an opportunity for us to invest in some of the community and neighborhood providers who could use that support to further develop the evidence base that's necessary so that they have programs that are effective, but they could then demonstrate their effectiveness. Because we are at that place where the selection of modalities and programs really looks to, well, we want to look at what's evidence-based. Those are the kinds of programs that are funded. That's where we want to place our money. There's very, very much value in that. But then we also need to make sure that we are not overlooking valuable resources in our neighborhoods. Our neighborhoods that are experiencing community violence beyond anything that we have seen before, where we have our children living in conditions of chronic stress and trauma, where we are looking at families facing the results and impacts of a pandemic. And these are families and children who are already dealing with stressful situations. I also want us to think about the fact that one of the things that we know about this pandemic is that it did hit everybody. Everyone's in fact affected by it. And that includes even our care providers and our educators. And so we need to really take a look at where can we invest these dollars to support even the providers, the caregivers, the educators. Where can we support families? Where can we support faith-based organizations? Where can we support neighborhood organizations? You know, I'm struck by Representative Exum's reference to Ebony Horsewomen, a neighborhood program in Hartford that does wonderful equine therapy. When we're looking, and we do have policymakers here, when we're looking at our children's behavioral health system, one of the things that we really want to focus on is how can we make it more effective as a cross-system, integrated, and fully collaborative system. And I would look at that cross-system integration from a number of different perspectives. Oftentimes we look at it from the perspective of let's make sure that all state agencies are working together. And that is absolutely a priority that we need to take into consideration. I want you to think about this. If I had time, I would put it in as a poll. But if you were to guess how many state agencies the legislature, in its wisdom, assigned to the Children's Behavioral Health Plan Advisory Board, I wonder how many of you would come up with the number 12. 12 different state agencies that are child serving. And then take into consideration that we know that there are some other public agencies that probably should be involved. Because when you're looking at creating that foundation that can support our children's behavioral health system, you need a variety of services and expertise, a variety of different resources that have to be brought to bear. So we are looking at how can we also, besides the public sector, how can we also make sure that our children's behavioral health system also has collaboration with our commercial side? I believe Zoe's mom pointed out the challenge that she's facing with the cost of care, the health insurance, and just know that what she portrayed is replicated many, many, many times by our children and their families as those families try to provide the services. So we do need to take a really close look at what kinds of difficult conversations we should be having, what kinds of questions should we be asking, what should the array of services look like in the commercial sector, what does it look like in the public sector, and how do we make sure that we build a child behavioral health system that ensures that all children can access the services that they need, and that we make that something that is more accessible for our families, because when your child is suffering, your family is suffering. So when we have that opportunity to build into our children's behavioral health system, robust family engagement and peer support, we should be using our funds to make sure that that is happening, but that also that it's something that's sustainable. So when we're having these conversations, we want to not only make sure that we are using those federal dollars effectively, that we're leveraging that funding with existing state funding, that we're doing all of those things to maximize the dollar, but we should also be making sure that we are looking at how are we going to make that sustainable for our children's behavioral health system so that we can share and support quality behavioral health services for all of our children in Connecticut. So the last thing that I think I would want to just have us to think about is we had an opportunity this morning to pull together a very strong representative group, but there are affected partners that are not represented here today. And there are voices that have not been heard. We are grateful for all that we did here, and we're grateful for everyone who took the time to be on here today. But I would put forward to you that we need to have more difficult conversations, and we need to make sure that we're having those conversations with those communities that don't often get an opportunity to share their voice and their perspective. So I thank you for this opportunity that you have given to me to make some observations and comments. And I thank each and every one who contributed so richly to the conversation that we're having today. Look forward to having more challenging and difficult conversations that will help us to bring Connecticut's children's behavioral health system to its optimal state, and it serves all of its children and all of its families well. Thank you.
And thank you so very much. And thank you for your leadership as part of the behavioral health collaborative. And I'll tell you, you hit it per usual right on the head. And it's really oftentimes when we hear the stories that we hear about limited numbers of beds. We hear the stories about parents not being able to navigate a system. We see the inequities in our that it seem to be baked into our system. These are all outcomes of decisions that are made by leaders about resources and about priorities. And what's so heartening in seeing so many of our leaders here today, not only as our panelists, as attendees, but also watching, is that leaders get that now, and they're listening, and they want to focus their resources on what really works in a way that's integrated and equitable. So, Anne, thank you so much for painting that picture for us, because I think it really did hit home to all of the other presentations that we heard today. And thank you so much again for the work that you do. And certainly last but not least, we're going to hear from Lane Taylor, Medical Director for the Village for Families and Children. Welcome, Lane.
Thank you so much. I'm so grateful to be able to be a part of this panel of just really impressive individuals who are able to be brave enough to tell personal stories, as well as be able to express the real issues, but come with very real solutions to what's happening in Connecticut. Today, we're talking about a mental health crisis for children, but these aren't someone else's children. They're our children, all of our children, and we're responsible to care for them. Nationally, there's been an increase in the rates of depression and anxiety and suicide amongst children and adolescents. Suicides, suicidal behaviors, and suicide thinking increased 1.5 to 1.75 times between March of 2019 and March of 2020 during the pandemic. At the Village, our statistics match these national trends. We had an increase in the rates of anxiety and depressive disorders since 2019. There have been an increase in the rates of children in need of the Village's mental health services by 50% since the pandemic started, since 2019. Children are not only presenting for services more, but are presenting with more severe conditions. It's important to note that this was in the face of the schools being closed, and schools were the primary sources of referrals for mental health treatment. So we weren't getting the referrals from children, from the schools. We were getting the referrals from kids, from families. But even with the increases in the rates and the increase in accessibility to treatment through telehealth, many children are still being left behind. While more children are being seen here at the Village, the percentage of children were higher from towns surrounding Hartford, and yet the number of children presenting to the Village from Hartford itself actually dropped by half. Who's left behind in these numbers? The gap in access and care is widening for Black and Brown children. Why are we seeing these trends in the US, and why in Connecticut? Well, I think the increase in discourse about mental health is much more acceptable and more present in popular media, which is good because it helps people feel more able to speak openly about their conditions, about what's going on with them. But when schools got closed during the pandemic, so many kids were left behind without the usual non-family or practitioner adult support that would be amongst the first to identify the beginnings of depression and anxiety in children and teens, and would be the people that would refer them for behavioral health support. The isolation of pandemic has hit the kids hard, particularly hard. And more children need mental health care and are presenting close to or in the midst of crisis. More kids are struggling, and more severely. The system is not prepared for this. In 2014, we were discussing a crisis of children being stuck in emergency departments awaiting hospital beds. I remember this very clearly. 7 years later, we have more kids requiring mental health treatment, but the types of mental health care programs we have the same types of mental health care programs. We have fewer providers, fewer programs for kids in crisis, longer waits for access to programs, and access to care is less equitable. That gap is widening. It's not an uncommon story that children are awaiting community treatment while in our subacute program, Eagle House. It's a difficult situation. The children in this program require high levels of support once stable to return to the community, but have to wait for these resources to be available because a gap in care may lead to decompensation and possible hospitalization. At the same time, no child should have to be out of their home when they're safe and ready to be with their family, in their school, and with their friends. I worked with a 9-year-old in our subacute program who was doing so much better than he had done in over a year. And he was ready to discharge back to his home. But because there was a 4-week wait for IOP, PHP, extended day treatment, and an 8-week wait for ICAPS, we had to postpone his discharge so that we would not risk him decompensating, him needing a higher level of care. This kid deserved to go home and continue his care with his family and in his own school. I've worked at all levels in the Connecticut mental health system, from outpatient clinics to residential to psychiatric hospitals and state psychiatric hospital for children. The story is the same, but seen from different angles. Children are struggling and there isn't enough. There aren't enough psychiatrists, there aren't enough therapists, there isn't enough program slots, there aren't enough hospital beds, there isn't enough support for preventative services. You've heard about the numerous problems within our mental health system, but what can we do about it? So parity and workforce issues were noted by Mr. Zavronsky and Dr. Mays earlier. These are necessary to build the infrastructure and assure that mental health care is accessible and equitable. Connecticut needs improvement in continuity of care. Episodic care on which the current system is built and how it's reimbursed can function well for children who do not have chronic mental health needs, but leaves behind the many children whose needs require years of service. Ross spoke eloquently about how the relationship matters in mental health care. So many children in Connecticut aren't afforded that relationship as a result of episodic care. Children cycle through the same services, but different providers, and they have to start over each time. A little bit like how there's constant need of repeating all the same information from parents, as Representative Exum mentioned. It's like Groundhog's Day for a lot of these folks, and care gets diminished. The actual treatment gets diminished. Additionally, the creation of a statewide and streamlined system in which bed triage and program placement can be done easily by a clinically trained individual would reduce wait times and allow for allocation of resources to areas with the greatest need. There must be investment in the development of preventative services and intermediate levels of care. Access mental health has been mentioned several times today, but this program has been cut in every budget since its development and is only sustained by federal dollars. It's our state's main prevention program and has poor investment. We need more approaches to prevention, innovation in this area, and we need more options for children before they enter a crisis. We need our legislators and philanthropists to listen to the voices of these families, understand the effort needed to get your child into mental health care, what it takes to pay for that health care, and how much the children are suffering. You have the keys to the car, and the families and providers know how to drive it. Let us all work together so that Connecticut can be a leader in mental health care and delivery. Thanks.
Thank you so much for that, Lane. And again, thank you so much for really helping us recap what we've heard today. When you think about the various components of the system that are asking for us as a state to coordinate our own selves and the way that we resource this need, it is not a surprise that we're hearing it from our young people. We're hearing it from families with lived experience. We're hearing it from our providers, from our hospital networks, all the way down to people who are doing the work on the ground. We're hearing it consistently, and it's ringing true that a coordinated system of care that integrates not only our agency responses, but also the responses of our agents on the ground is really what's needed here. I'd like to turn, as we come to a close in today's first part of our conversation, to our child advocate to see if she has any final reflections as we move on with our agenda.
Thank you, Stephen. I just want to thank all of our participants for being here and really thinking, I think, as Ann Smith pointed out, about all the voices that aren't here today. And I really appreciate all the people sharing in the chat about their experiences, the experience of the families they work with, the experience of their communities. And I part of my takeaway here today is that everybody has a story. My mother used to say, my mother was very involved with NAMI, and she used to wear a button that said, 1 out of 4 people are affected by mental illness. And then she and I would say that the button was wrong because really everybody is affected. There's nobody, I can say with complete confidence that there's nobody participating in this webinar or watching that hasn't themselves struggled or have a loved one that has struggled with fear, despair, grief, anxiety, concern over a family member, depression. And it's not people's job to tell their personal story. But the more we can identify with one another, the more we can include all of the voices from our community and normalize the discussion about what individuals, children, and families really need. We will start to really get to a place where there aren't waiting lists to get the care that you need, where hospitals aren't overwhelmed with numbers from the community so that people have to sit in their hallways, right? Where families don't have to go home with a child in crisis, not wondering when someone will be there to help them, right? And nobody wants that. And we can do better, and we will do better. And I'm inspired by the stories that folks shared. I'm inspired to be, to reach out as much as we can to make this a continuing conversation. I'm so grateful for all the groups that I see represented in our participant list and who are watching, who are doing work every day, connecting with families, answering phones, going to people's homes. So many helpers doing work that is so needed and so hard. So I have gratitude, I have humility, and I have resolve to keep working on this with you. And so thank you to everyone for being here today. I turn it back to you, Stephen.
Thank you so much, Sarah. And thank you again to the leaders who have joined us today on our call. Some of you have shared your very personal stories. Thank you for the providers who have joined us as well. But most importantly, thank you so much for those of you in community who have shared your personal stories that have been heard and that really will be the fuel, continue to be the fuel for the work that we're doing here in this important area. And finally, I'd like to welcome you back next week, where we will continue this conversation. Next week, we will be taking some of the recommendations that we heard today and discussing those recommendations with leaders who have the ability to help start coordinating these efforts, continue to coordinate resources in important ways, and also marshal new resources that may be coming to the state from the federal government, as well as our local philanthropic dollars and state agency dollars. So again, thank you all so much for joining us today. This has been an incredibly important and enlightening conversation in light of what so many of us are going through today. So again, thank you. Thank you all. Thank you for those of you who were in the attendance. And thank you to CTN, as always, for covering today's broadcast. Have a good afternoon.